Hey everyone, thanks for joining Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an adult anesthesia and ICU provider, physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company in Baltimore County, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of Dr. Andy Pollack in the medical director's office, on behalf of the EMS office, Director Shenning, Captain Stewart, Captain Natz, thank you for what you guys do every day. Thank you for your dedication to lifelong learning. A big shout out today to Ashley Brooks, who's online with us. Ashley is the young member and volunteer at Pikesville Volunteer Fire Company. She is helping us with our live stream. She is also the one who's going to be helping us with our CEUs. Ashley will be sending out a link at some point during this presentation in the chat. Click on that link, provide a little bit of information, and we can get you your MIM CEUs. So if you want your MIM CEUs, keep an eye out on the chat, click the link. If you have any challenges getting that information into that form, you have to let us know, please, during this training. We'll also stay on at the end if you're having some challenges. We need to resolve attendance, make sure that we've documented attendance prior to leaving this forum or this training tonight. So tonight, we're exceedingly excited to have Lieutenant Dave Snyder. Lieutenant Snyder is EMS 5D in Baltimore County Fire Department. Among his many accomplishments, Lieutenant Snyder is the author and creator of Geriatric Education for Emergency Medical Services, or GEMS, which is a national continuing education program for emergency EMS providers. The text and educational program have been adopted by the National Association of EMTs and is published by Jones and Bartlett Publishers. That program is now being taught around the globe. Lieutenant Snyder is now working on developing similar high value educational programming around bariatric care. Lieutenant Snyder, thank you so much for joining us tonight and sharing your wisdom. Thank you.
Sure. Are we ready to begin?
Yeah, we're all ready.
Okay, everyone. Thanks for tuning in. As everyone knows me, and everyone also knows I'm not very computer savvy, so we're going to try this. Tonight's presentation is care and transport of the bariatric patient. I will say that this is a work in progress. We're still developing the program, but I think we're about 90% done. I also think it's timely because, as everyone knows, we are in the process of receiving the 3 new bariatric units. A brand new bariatric SOP will be released, as well as this training program, perhaps modified a little bit. This is eventually, our hope is to put this up on the Fire Academy's LMS program, and it will be required for everyone, because we thought that if we're going to get the new bariatric units and we're going to get a new bariatric SOP, let's do some comprehensive training on not only the use of the bariatric units, but also the complete care and transport of the bariatric patient. So I was not as savvy as getting my notes where I wanted them to be. So if you see me look away from the camera, I'm looking at my notes. So here we go. So this was developed by me. I would assume that Dr. Barinholtz has already addressed that. At the end of the program, we'll get our continuing education hours. So tonight we're going to understand the incidence and prevalence of obesity. We're going to understand assessment of the obese patient, which can often be challenging. And we're going to understand transport considerations of the obese patient. And we're going to take a look at the bariatric equipment utilized by our department. Now, this is the only section that may change somewhat because it's based on the current equipment that we have now. The new equipment may be somewhat different, but the overall concepts will still be the same. So what slide are we on for? So this is the time I have to look away. So what is the definition of obesity? The Obesity Medical Association defines obesity as a chronic, relapsing, multifactorial, non-neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces resulting in an adverse metabolic, biochemical, and psychosocial health consequences. And I read that because it's very long and it's very complicated. But this is a multifactorial process. How do we define obesity, and what do we put on as a definition? For clinical purposes, I tend to define obesity as anybody in excess of 300 pounds. And I say 300 pounds and roughly 150 kilograms because that's where we come into medication dosing difficulties. Now, we know that our bariatric units or our power lift stretchers are rated at 750. So we're not using 750 pounds. So we're not using 750 pounds as a definition of obesity. I'm using 300 pounds. Access is difficult to define. Now, adipose tissue or fat tissue, morbidly obese patients or obese patients don't have more adipose tissue than somebody that weighs 120 pounds. Adipose tissue has the ability to expand indefinitely. So obese patients have the same amount of adipose tissue as anyone else. And in scanning the literature over the years, there is a lot of negative stereotyping when it comes to older people. See, I'm in that mode. When it comes to obese patients, there's a lot of stigma associated with obesity, and a lot of prejudice toward obese people by healthcare workers. I don't think we have that problem in all the bariatric calls that I've been on. We've treated bariatric patients very kindly, very humanely, and we treat them like everybody else. And that's, what I would expect from our people. But just know that there is a lot of stigma and prejudice associated with bariatric patients in the healthcare community. And unfortunately, bariatric patients are aware of this. Body mass index. This is body mass index is used by the Centers for Disease Control and the World Health Organization. It's a person's weight in kilograms divided by their height squared in meters. And I think everybody, when you go to the doctor, you get your BMI, and it's based on your height and your weight and your body structure. A BMI of over 30 is considered obese. Now, when we respond to bariatric patients, obviously we don't ask them. We anecdotally know this is an obese patient. But a BMI of 30 is considered obese. So I think after this, probably a lot of people are going to be weighing themselves, looking at their body structure and seeing whether or not they're obese. So who's obese in the United States? And you got to bear with me because this is a work in progress and my technological skills aren't what other people's are. 39.8% of adults aged 20 and over were considered obese in the United States, with another 7.6% considered severe obesity. I think anyone that's been around in the department any number of years can remember we frequently transported a 1,000-pound gentleman to the hospital. He subsequently died in Dundalk and on Kavanaugh Road. And these transports, and I'll say this to the providers and the officers that may be listening, EMS and suppression, these are not quick moves. These are, unlike nursing home patients, we put the stretcher next to the bed, we put the 90-pound nursing home patient on a stretcher and we go. These patients or these calls take a lot of consideration. Every move has to be planned, not only for the comfort and safety of the patient, but for the safety of the crews as well, because once we start the move, we're into it. The state with the highest percent of obesity is Mississippi. Lowest percent is Colorado, and Maryland ranks 25th in the nation for obese patients. So obese patients, again, part of the stigma is people have a misrepresentation of obesity occurs from overeating due to a lack of self-control. This really is not true. It's not true at all. We get into the clinical aspects a little bit. Obesity is actually a form of malnutrition, believe it or not, malnutrition. Malnutrition refers to deficiencies, excesses, or imbalances of a person's intake or energy and or their nutrients. The term malnutrition addresses three broad groups, one of which is overeating and obesity. Now, for the paramedics and clinical people in the room, hypothalamus controls hunger and eating. The ventromedial nuclei gives a signal when to stop eating. It's not your stomach. People say, man, I'm stuffed. My stomach can't hold it anymore. It's not your stomach saying, okay, enough, get back to the table. It's actually a signal in your brain saying, we have had enough. So we feel full at the brain level because of the function of the ventromedial nuclei. There's some evidence that suggests that disturbances in the ventromedial nuclei don't allow people to feel full, which leads to obesity. That makes sense. So obesity actually is a form of malnutrition. Now, we generally think of malnutrition as people that are emaciated and very skinny. Yes, they are. But there's also people that are obese also from malnutrition because simply they're not eating the right things. There's a lot of causes of obesity, genetics, behavioral. There's a big genetic component now to obesity, behavioral, social, cultural, environment, poverty, and there's certain disease processes that lend itself to obesity. These diseases, the disease process I'm talking about are probably less than 1% of those people that are morbidly obese. But more commonly, people who have obesity have multiple genes that predispose them to gain weight. One of the genes, one such gene is the fat mass and obesity associated gene, which is found in up to 43% of the population. Obesity promoting behaviors include frequent fast food consumption, eating occasions away from home, large portions. We don't have that problem in the fire department, though. High consumption of beverages high in sugar, and the omission of breakfast. I mean, it is true. People say, well, breakfast is the most important meal of the day. A correct, nutritious breakfast, that couldn't be more from the truth. No less real are the social and emotional effects of obesity, including discrimination, lower wages, lower quality of life, and likely susceptibility to depression. Sedentary lifestyle also causes overweight and obesity. Research conducted at Harvard first linked TV watching to obesity. Don't turn this off. This is educational. The Harvard study linked TV watching to obesity more than 25 years ago. Environmental factors like high fat foods, supersized portions, fast food consumption play a major role in the occurrence of obesity. Individuals addicted to high fat and calorie high and inexpensive food, people that eat McDonald's or fast food restaurants, I shouldn't say McDonald's, people that eat fast food every day, or there's a big correlation between poverty and obesity because they don't have access to healthy and nutritional foods. Now, there's the diseases that I talk about are that are linked to obesity are pharyngiomas, iatrogenic causes. Some of these you can look up if you wish. Cushing's disease is linked to obesity, Lawrence-Moon-Goodall syndrome, and Prader-Willi syndrome. Now, most of the folks and there will be a link on when we do this presentation on the LMS. There will be a link that you can click on the pages to take a look at all those diseases. I think most people are familiar with Cushing's disease, but not familiar with the other two diseases. The other two diseases are also linked. Also linked to I'm having a the other two diseases are linked to we'll skip that. I'm having a COVID moment. The LMS presentation, I guarantee, will be much more smooth. So what are the causes, what are the medical risks of being obese and morbidly obese? Hyperglycemia, too much insulin resistance, high cholesterol, high triglycerides, also decreased growth hormones. There's several endocrine and metabolic changes brought about by obesity. They include elevated blood sugar levels, elevated triglycerides, and decreased growth hormone and gout. You'll see a lot of morbidly obese people with gout. What are the cardiovascular risk? There's medical risk, cardiovascular with obesity, hypertension, coronary artery disease, congestive heart failure, varicose veins, and cerebral vascular disease. Excess weight and obesity are associated with an increased risk of cardiovascular diseases. Obesity has an important role in atherosclerosis and coronary artery disease. Obesity also leads to structural and functional changes of the heart, which we'll see in a minute, which causes heart failure. Atherosclerotic vascular lesions of patients with a higher body mass index values are more frequent and advanced compared to subjects with normal body weight. In the case of non-STEMIs affecting considerable, the most important risk factor ahead of smoking. The higher the body mass index, the sooner the non-STEMI will develop. The same relationship can also be observed in the case of ST elevation and MIs and STEMIs. Based on the data available, obesity is an independent risk factor for STEMIs developing at a younger age, but at the same time, excess weight can also be related to other vascular events. An increased body mass by more than 4% raises the risk of ischemia, and 6% raise the risk for hemorrhagic strokes. Studies on heart failure show that 32 to 49% of patients suffering from heart failure are obese and 31 to 40% are overweight. In the case of obese and morbidly obese patients, heart failure develops 10 years earlier in the case of subjects who are not obese. Numerous studies have also demonstrated the increased risk of cardiovascular arrhythmias and sudden cardiac death. I was just reading my notes. Hippocrates in the 4th century, he noted that sudden deaths are more commonly to patients that are fat than patients that are lean. So obviously we've known about the risk associated with obesity for some time. Obese patients have a 1.52 times higher risk for the development of AFib compared to normal weight population. According to a meta-analysis published in 2014, the frequency of left ventricular hypertrophy in obese patients is 56% higher than those that are not obese. So we'll take a look. So you can take a look at this. The heart on the left is from an individual of normal weight. The heart on the right is from a morbidly obese patient. So take a look here, the normal heart on the left, and then take a look at the heart on the right, and you can see how much bigger that heart is and where all the fat is around that heart. What are the pulmonary risks of obesity? Obesity causes mechanical compression of the diaphragm, the lungs, and the chest cavity, which can lead to restrictive pulmonary damage. This is why we try never to lay a morbidly obese patient supine. Now I know that's difficult sometimes with our extrication, particularly in and out of the house off the 2nd floor. However, I've done Stokes basket evolutions with morbidly obese patients where you have to lay them flat, but laying them flat does cause a risk because they can't overcome the mass and the weight of their chest cavity against their ability for excursion. Dyspnea on exertion is a common complaint of morbidly obese adults. Almost 40% of obese individuals complain of dyspnea on exertion, an increase that is higher than the general population. Obesity is the most common known risk factor for the development of chronic obstructive sleep apnea. Some individuals who develop obesity hyperventilation syndrome, which is defined by the triad of obesity, daytime hyperventilation, and sleep disordered breathing that represents hyperventilation that occurs in the absence of a neuromuscular, mechanical, or obese. They call that the Pickwick syndrome. Old people that have sleep apnea comes from Joe the Fat Boy in the Charles Dickens posthumous papers of the Pickwick Club in 1836. And I have not seen Joe, but apparently Joe consumes large quantities of food and falls asleep in any situation, any time of the day. Most of the morbidly obese patients that we encounter, when you see them, they're sleeping on multiple pillows, just like COPD patients. And some of them have not left their bed, their room, or their house in several years. We had one bariatric patient one time, he had been in his bed for 6 years and he hadn't moved. It's very difficult for them to get to a doctor's appointment. It's even more difficult for them to get to the emergency department. They can't do it on their own. And so when they do call 911, they are in a clinical crisis. Gallbladders or gallstones are more common in obese patients. Let me see my notes on that. People who have higher obesity tend to develop higher levels of cholesterol in their bile, which causes stones. Now, musculoskeletal, the increased risk of obesity or osteoarthritis, chronic orthopedic problems, and decreased ambulation. A lot of morbidly obese patients complain of pain to their knees. We take a look at this person on this slide. You can see why a lot of them have chronic knee pain. It's associated with functional limitations in muscle performance and the increased likelihood of developing a functional disability, such as mobility, strength, posture, and dynamic balance limitations. Some of the younger obese patients that we see in our setting, they can walk if we assist them. And oftentimes, I know we don't walk patients with trouble breathing or chest pain, but in the setting of young obese or morbidly obese patients, it's actually easier on them if we can help them ambulate a couple steps. But when we help them up off their bed or wherever they are, if you watch them, a lot of them are off balance because they haven't been up in a while. The renal-ish risk with obesity. Obesity is a potent risk factor for the development of kidney disease. Obese individuals, kidneys have to work harder, filtering more blood than normal to meet the metabolic demands of the increased body weight. The increase in function of the kidneys can damage the kidneys and heightens the risk of developing chronic kidney disease in the long term. Oncology. There's an increased risk of endometrial, breast carcinoma, particularly in postmenopausal women, prostate, colon, esophageal, kidney, and pancreatic cancer. So when we look at the dermatological risk associated with obesity, a lot of them have the, let me see what slide we're on. Again, bear with me, this is a work in progress. Obesity increases the risk, which is associated with more than 30% of medical problems, including dermatological problems. You can see the line in the back of the neck. They also have a lot of, they could have weeping sores under skin folds. This is particularly why gown up, glove up, because a lot of them have rather than have infections under their skin folds. But this, they're also at increased risk of MRSA, BRE. Psychosocial risk with obesity, depression and loss of self-esteem. Now, this is many morbidly obese patients are depressed, and they have decreased employability. They're not going to get up every day and go to work. This leads to poverty. This leads to a lack of access for decent food. This leads to increased weight gain, and this leads to impression. So it is a vicious cycle with a lot of morbidly obese patients. So you can, hopefully we've already seen by now that hopefully we've got rid of some of the stigma that people may have, that this is not a disease where they sit around, eat potato chips, bonbons, and watch soap operas every day. It just isn't so. Morbid obesity is considered a disease. And I think that we need to treat it as such, that like any other disease, like diabetes, like hypertension, and like cardiovascular disease. So I hope that when we view obesity as a disease, we look with a little more empathy toward our bariatric patients. Pregnancy. It worsens underlying hypertension, diabetes, and there is an increase in maternal morbidity. I have had some obese women of childbearing age who are pregnant, and they do understand the risks. Excuse me. Sorry, dry talking. The medical risks with obesity, and Dr. Barinholtz, please feel free to jump in here. Surgery, especially under general anesthesia, increases the perioperative morbidity and mortality. I think and I hope Dr. Barinholtz will agree, it's getting them out from under the anesthesia that is the problem. Would you agree, Dr. Barinholtz?
Yeah, that's exactly what we were just talking about. I absolutely agree.
And it's not uncommon that we could see this type of patient in an outpatient surgery center. I still find outpatient surgery centers in my district that I didn't know were there, and I've been there for 17 years. So they're everywhere. But this slide kind of sums up the medical risks of obesity. And we can see that they are many: asthma, pulmonary blood clots, fatty liver, cirrhosis, gallstones, the cancers that we just talked about, arthritis, particularly at the knees, inflamed veins, often with blood clots, gout, heart disease, diabetes, abnormal lipid profile, high blood pressure, pancreatitis, and generally female disorders such as, I believe we call it dysmenorrhea, with their monthly periods, and infertility as well. So again, just bear with me on this, because again, it's a work in progress. These slides will be available once the bariatric units are ready to go and we roll out the training. So you'll be able to have these, and you'll be able to see them and review them as you wish. I'm working with two computers here, and that's a problem. Bariatric surgery. There's 4 kinds of bariatric surgery. We beginning to see a fair number of post-surgical bariatric patients with complications of their bariatric surgery. And we're going to spend a few minutes talking about this, because I'll cut to the end now. Patients that are having complications post-bariatric surgery cannot be taken to any emergency department. They need to be taken back to the hospital where they had the surgery, or if they're from out of town or they're not from this area, they need to be taken to a hospital that has bariatric surgical capabilities. Because any hospital, any emergency department that does not, or any hospital that does not have bariatric surgery capability, does not have the surgical expertise or the hardware to manage post-surgery bariatric complications. So there's 4 kinds: Roux gastric bypass, laparoscopic adjustable gastric banding, sleeve excuse me for 1 minute. Sleeve gastrectomy, and biliopancreatic diversion with duodenal switch. Now, is it important that we memorize all the types of bariatric surgery? No, it is not. Because if we respond to a patient with a complication from their bariatric surgery, they will know what type of surgery that they have. And for the most part, we're going to treat these patients symptomatically like we would any other patient. But the patient will know the type of surgery that they have. So just going to spend a few minutes talking about these surgeries, because I think this is information. And again, you don't have to try to remember it now. It'll all be available once it goes up on the LMS. But I think this is information that we're not taught in initial training programs, and we don't get any continuing education on a regular basis about bariatric patients, their health risk, or the complications of bariatric surgery. So I think it's worth spending a few minutes on. Roux gastric bypass is considered the gold standard. It's a surgical procedure in which the stomach is divided into a small upper pouch and a much larger lower remnant pouch And then the small intestine is rearranged to connect with both. And here's a picture of it. On the left is the stomach before the surgery. On the right is the stomach after the surgery. And you can see that the majority of the stomach is bypassed. So patients that have the surgery, they eat less food because the stomach simply can't handle the volume of food that they had before. Laparoscopic adjustable gastric banding is another type of bariatric surgery. And in this surgery, an inflatable band is placed around the upper portion of the stomach, creating a small stomach pouch above the band and the rest of the stomach below the band. With the smaller stomach pouch, eating just a small amount of food will satisfy the hunger and promote a feeling of fullness. Now, Dr. Barinholtz, you may want to chime in on this as well. I recently learned that this gastric banding, that the patient sometimes has the control. Before I go, you can see the slide, and you can see where the gastric banding is. It's just not going to allow as much food to pass through the stomach, into the stomach as before. But I believe that in some of the newer surgeries with gastric banding, the patient is actually allowed to adjust the band and regulate the tightness of the band. I'm not sure that that's true. You may have to chime in on that.
I don't know. I don't work at a bariatric center. I am learning like everyone else from you. But I would say that we are going to have a bariatric surgeon in an upcoming talk, talking about the complications in detail.
Oh, very good. So he'll address that. But I believe that this port that you see exiting the band allows the port to be tightened and loosened by the patient. Sleeve gastrectomy. Sleeve gastrectomy is a surgical weight loss procedure in which the stomach is reduced to about 15% of its original size by surgical removal of a large portion of the stomach along its greater curvature. So you see, there's this portion of the stomach is actually removed, and what you're left with is just a very small portion of the patient's stomach. Less intake, less weight gain. That's the goal behind that. Biliopancreatic diversion with duodenal switch. Okay, this is a procedure that has two components. First, a smaller tubular stomach pouch is created by removing a portion of the stomach, very similar to the sleeve gastrectomy. Next, a large portion of the small intestine is bypassed. So we see this would have been the original stomach. Okay, this portion of the stomach is bypassed this portion of the stomach and the small intestine is bypassed. So again, you have a smaller pouch. The goal of all these surgeries is a feeling of fullness or less food intake because the stomach is smaller, hence the weight loss. And, you know, I think we've all seen people in our own department and where we know people that have had one of these different kinds of bariatric surgery, and the weight loss is very impressive for patients. Are any of these reversible? Some are, some aren't. And I believe in the gastric band can be removed, but most patients elect not to have that, particularly if the band can be adjusted. For our purposes, this is what is important to us. Again, do we need to memorize the different kinds of surgery? No, the patient will know that. What we're interested in is what are the complications post-bariatric surgery that we may become involved with. Less than 30 days. Common complications include bleeding, wound infection, leakage, intra-abdominal abscess, stricture, early obstruction, and nutritional concerns. Greater than 30 days out, complications include intra-abdominal abscess, obstruction, hiatal hernia, gallstones, marginal ulcer plus perforation, marginal ulcer plus bleeding, strictures, GERD, slippage, prolapse, erosion, and nutritional concerns. What would be the overall complaint for these patients is abdominal pain, signs of leakage or infection. Questions that we need to ask of the bariatric patient. And again, you don't have to write these down. These are all be up on the LMS. What procedure did you have? Very important. Where was the surgery performed? Who did the surgery? When was the surgery performed? How was the surgery performed? Was it laparoscopic? Was it open? Or was it a revision from previous surgery? And when did the symptoms begin? What are the vital signs? Fever, tachycardia can be an early sign of a leak. Again, fever, tachycardia, early sign of a leak. What are the physical findings that you see? You do have to inspect the site. Where's the pain or complaint? Usually it's in the abdomen. And again, like any other patient with unstable vital signs or the patient's deteriorating, it's ABCs, O2, IV, monitor, and fluid bolus. And again, I said in the beginning of the lecture, these are not quick moves. Every move has to be planned out. Number one, we have to have adequate amount of personnel on the scene to do it. We have to have the adequate resources to do it. I've used the ATR team before. I've used an articulating platform. Stokes basket evolution can be done, but it's risky. If you have a platform such as Tower 322, that's good. The Stokes basket or can be put out on the platform. These are patients that are not going to fit on a traditional backboard. The Reeve sleeve is questionable. I've used the Reeve sleeve with some success. I've also used a Reeve sleeve where the sheer weight of the patient has snapped the wooden boards on the inside. Every EMS district officer carries, or every truck company rather carries a skid, and every EMS district officer carries the large tarp, which is weighted to 1,600 pounds. Problem with the tarp is there's no supporting structure underneath to support the patient. But sometimes we have to improvise and do the best we can. But again, this is where I said that once we begin a move, we have to think it through. Where do we need to go? How do we need to get there? And what interventions are critical to do on Zine? I think oxygen therapy is definitely paramount. I'm going to go out on a limb and say this, but again, this is a work in progress, so we're still developing some of the clinical pearls. Is it appropriate to put a morbidly obese patient on CPAP that is having mild to moderate respiratory difficulty? It may, simply because the move can often complicate their breathing problems, and if we have to lay them supine even for a few minutes, their breathing difficulty could be worse, and perhaps the CPAP will overcome some of that. Don't go out and do it tomorrow and say Snyder said so. We're thinking outside the box because, I have to go back. I mean, 25 years ago, we weren't doing some things that we needed to with pediatric patients, and we've had a ton of pediatric training, so we now have pediatric appropriate equipment. We now know how to drug dose pediatric patients, so we've come a long way in the care of pediatric patients because we've been educated. I've tried to do the same thing with geriatric patients, but I think the care and management of the morbidly obese patient, particularly in the pre-hospital setting, is ever evolving. When I scan the literature, the medical literature, the EMS literature, particularly the medical literature, very, very few articles on the emergent management of the bariatric patient because it just isn't there. Medication dosing is very difficult in morbidly obese patients, other than weight loss drugs, because they don't make good study subjects because of all their comorbidities. Same thing with geriatric patients, and it's also the same thing with bariatric patients. And I shudder to say this because sometimes I get emails that aren't so pleasant when I say this, but where has particularly anesthesia and emergent, the drugs that ACLS drugs, medical science has learned a lot from veterinary science when in terms of emergent drug dosing, anesthesia, because you look at the gorilla because it has the same and this is where I get in trouble when I say this, because the gorilla has the same body structure as a human, and they have a very, very high fat content ratio. So one of the difficulties that we have is medication dosing. That's why I say, this is ever evolving. I mean, I'm continuing to do the research, but I think particularly when we move patients, they have deteriorating vital signs, keeping them well oxygenated is absolutely paramount. But, I also talk about IVs and fluids and fluid bolus. Very difficult to gain IV access, but we're going to talk about that just a little bit later. So I said earlier that bariatric patients should go back to the hospital where they had the surgery, or if they were not from our area, they were passing through and they need to go to a hospital that has bariatric surgery capabilities, where are they in our area? TBMC, Hartford Memorial, Johns Hopkins Bayview, Franklin Square, Northwest, St. Agnes, and University of Maryland. So I think wherever we are in the county, we have access to a bariatric hospital where more than likely the patient had their surgery, or that we can get to fairly quickly, even if the patient is from out of town. Please don't take these patients to the closest emergency department. Remember, the closest appropriate emergency department. And with bariatric patients that are having complications, or bariatric patients that, in general, if you can get them to a bariatric surgery hospital, again, they have the surgical and technical expertise to care for morbidly obese patients. Early consult is preferable because the ER sometimes need to get the proverbial big boy bed into the ER. That may take them some time. Even if you call and say, hey, we have a morbidly obese patient, this is what we're here for. However, it's going to take us some time with extrication. You give them a quick heads up and they can get the equipment out that they need, or particularly the bed capability that they need. And a lot of times I've seen where the bed's actually brought out to the ambulance entrance, and we do the transfer there because we have more room than in some of these 4x4 rooms that we go into in the emergency department. So GBMC, Hartford, Hopkins, Franklin Square, Northwest, St. Agnes, and University of Maryland are the hospitals in our area that do bariatric surgery. Please take these patients back to there. Let's talk about obesity medications. Now, obesity medications have been around for some time. These patients will be probably on one of them. I just picked the first few, or the most common ones that patients are on. The problem is with obesity medications, toxicity and overdose is understudied on these medications. It's a very small segment of the population. So overdosing and toxicity of these medications is often not known. Xenical, you can buy that over the counter, I believe. Yes, it is over the counter. It's called Ally. It reduces the amount of fat your body absorbs from the food you eat. And you'll see throughout this, side effects are generally the same: diarrhea, gas, leakage of oily stools, and stomach pain. Okay, and again, Ally is the over-the-counter version of Xenical. But what are the overdose effects of it? Simply don't know. Velvic, you see that advertised on TV. It acts on the serotonin receptors of the brain. It may help a person feel full even after eating smaller amounts of food. Side effects: constipation, cough, dizziness, dry mouth, feeling tired, headaches, nausea. I would suspect that the dizziness and the headaches and the nausea are what we would be called for. Phentermine, it's a mix of two medications here. This Quizmia is a mix of two medications. Phentermine, which lessens the appetite. Excuse me 1 minute. And topiramate, which is used to treat seizures or migraine headaches. Again, it makes a person feel less hungry. Side effects: constipation, dizziness, dry mouth, taste changes, particularly with carbonated beverages, tingling in the hands, feet, and trouble sleeping. Contrave, it's a mix of two medications. and it's also used to treat alcohol and drug dependence, but it's used to treat depression or to help people quit smoking. It may make a person feel less hungry or feel full sooner. Side effects. I think by now you've started to see some commonalities: constipation, diarrhea, dizziness, dry mouth, increased blood pressure, increased heart rate. Two side effects that are undesirable in morbidly obese patients: insomnia, nausea, and vomiting. So just like every other patient, ask the bariatric post-surgical patient or the obese patient, are you taking any weight loss drugs, and what are they? And write down the dosage. Saxenda, we see that advertised on television as well. Again, it makes a person feel less hungry or feel full sooner. At lower doses, it's packaged as Victoza for type 2 diabetes. You see this advertised for type 2 diabetes all the time, but there's always that, they get that in at the end. And there's also possibility of weight loss. So-and-so lost 8 pounds in the first month. Victoza is used for diabetes, but it's also used now for the management of obesity. Side effects: nausea, diarrhea, constipation, abdominal pain, headache, and an elevated pulse rate. So some of the side effects of these obesity medications are undesirable in the morbidly obese patient. Management issues. Dr. Barinholtz, I'm going to ask, do you want, at 7:51, do you want to take a 9-minute break and resume at 8 o'clock? We've been here 50 minutes.
Sure. I think you want to do 5 minutes?
Let's do 5 minutes, and then we'll come back and we'll pick up. I think this is really the important. I mean, the first part is the background. It's nice to know information. I think it's information that we don't get in our initial training programs, and we don't get in continuing education programs. And again, I know we rolled through the first hour fairly quickly, but again, once we fine tune this presentation, it will be available on the LMS, hopefully narrated a little more eloquently than I have done tonight. But all this information will be there. I just want you to, tonight, to think about some things. But I think the important part is in the next hour, where we talk about the assessment, the treatment, and the transport of morbidly obese patients. So let's take 5 minutes, and then we will resume.
Sounds good. Thanks so much. Hey, everyone in the chat. Also, Ashley sent out the link. If you want to click on that link, you can go and fill out the information to get your CEUs as well.
See. Oh.
When did you stop? 7:53. That's 7:55. Yeah. He's very entertaining. He buys in. 7:55.
Is everybody back?
Hello,
Hello?
hello, hello,
We were in a classroom. I could count the seats.
hello. Something just dropped down. What's that? That just dropped down. Hello? It drops. I don't.
Dr. Barinholtz, are we ready to go? I'm
Hello?
gonna wait for Dr. Barinholtz to come back and then we can begin. Okay.
Hello?
So there are also, yeah, welcome back. So there are also some comments in the chat as well. Do you want to run through those?
Sure.
Can you see the chat or would you like me to read them to you?
Please read them.
Yeah. So someone says, are they able to stretch the sleeve back to where they were before?
That I don't know. I think these are probably all great questions, some of which I may or may not have the answer to, but I think when you get the bariatric surgeon here, he obviously can answer all those questions. That's one I don't know.
Yeah,
I know this.
I think there could be some stretch for sure. I think there's a risk certainly that it's going to rupture if it gets acutely distended. And I don't think that the stomach has the capacity certainly to stretch back to the original size, for sure not. Maybe just they could stretch a little bit. And then it says, do these surgeries lead to malabsorption issues or electrolyte imbalances?
I do know that post-bariatric surgical patients are on a lot of supplements, particularly vitamin supplements. So the answer is yes, because they're getting now that might be a double-edged sword. I mean, they've had the surgery, and I think that after the surgery, and your surgeon will be able to talk more about this, they get a dietitian and a nutritionist to help them to guide them through moving forward nutritionally how to eat. I think if they fall back into their old eating habits, the answer is they're probably that's not going to help. But I think with the proper nutrition, they should be absorbing. But I do know that they do get the aid of a dietitian and nutritionist after the surgery.
And then someone commented that early signs of leakage sound a lot like sepsis.
Could be.
For sure, right? Because it's
Could be. Because some, elevated temperature and abdominal pain, yes, elevated temperature, and they certainly could lead to sepsis. You have to be very careful because I know we talk about that's a very good point. We should, I will look into that, perhaps with your help. We look at sepsis and we look at the fluid bolus with sepsis. I'm not sure about sepsis in a morbidly obese patient if massive fluid is often the right thing because of all the underlying comorbidities and the hypertension that could exist, both pre-surgery, post-surgery, and with some of the bariatric medications. So I don't know. That's a very good question. That I will get the answer to and try to email it to you.
Yeah,
Are
I
we-
think that based upon my own clinical practice in the ICU, I think, certainly that these patients, this inflammatory response, depending upon a wound infection, for example, or spilling intestinal content outside of the intestine and that kind of soilage, definitely it triggers an inflammatory response that needs to be resuscitated. Yes, maybe resuscitation is a little bit more guided once they get to the hospital with, ability to do echoes, for example, and to be able to follow somebody's intravascular volume. But I certainly think that if they're hypotense in the field, they need to be supported like other patients with sepsis, for example. Somebody said Good Sam used to be a bariatric hospital. Do they not do them anymore? They put a hoist lift in their EMS entrance.
They're not on the list. This list came from the metabolic surgery website, and they list, you can go by state and list these are accredited bariatric surgery hospitals. These are the ones that are accredited, and those are the ones that came up. I mean, there's more in Maryland. These are the ones that came up in our jurisdiction and Baltimore City. So I can't answer.
Yeah, and somebody else said pretty confidently, they said Mercy is now doing bariatric surgery too.
I'll have to go back to the list, but those are hospitals that I had listed are the ones that are accredited by the Metabolic Surgery Association.
They're probably coming online.
Great.
And I would think that more hospitals will
That's right.
come online, just like stroke and stroke hospitals and other specialty hospitals.
I agree. And as hospitals, right, try to seek accreditation for that, for
But
sure.
these are the ones that are accredited and that are in our area now that we know for a fact that we can transport these post-bariatric surgery patients.
But it also points to what you were saying before, that they should be going back to where they had the surgery.
Oh, absolutely. Taking them to any emergency department that does not have this capability will not be good because they don't have the surgical expertise and they don't have the equipment. Sometimes if they have to go back into surgery, they're going to have to be transferred, and depending on the emergent nature of it, let's get them, avoid the middleman, as it were. Let's get them straight to, just like we do with stroke patients, just like we do with STEMI patients. I think this is really no different, but again, it's something that you just don't talk about.
Good. I think that's it for the chat. Thanks so much.
Sure. Well, I hope everybody is back, had the opportunity to get their high fat content snacks, and is enjoying the weather today. I actually went to the mailbox without my cardigan. So those of you that know me know that that's yeah, the mailbox is standing after the plow got done with it. So this is the meat of this is really the meat of the program. The assessment, treat, and transport of morbidly obese patients must be given careful consideration. The provider must assess both the patient and the scene. This is paramount for bariatric patients that are not mobile. There must be sufficient resources on hand before you move the patient. Additionally, again, we talked about this already, each move has to be carefully planned out. That is, how will each move affect both the patient and the provider? And again, early notification to the hospital, just give them a heads up that we have this patient, here's a complaint. We have some extrication delays. This is anticipated what time we'll see you, and we'll make consult once we get in transport. We do that now for 1050i rescues, hopefully when we have a critical patient. But I think with bariatric patients, you have to give an early heads up. So here we are. This just illustrates your typical bariatric patient. And I apologize because I did not black out their faces. These were images that I retrieved. So I apologize for not blacking out their faces, but you can see the issues, particularly in the upper screen. There doesn't look like a lot of room to do assessment and transfer. So there is a lot of moving around of things because once we go, we're going. Now, will either of these two patients fit on a regular stretcher? The answer is absolutely no. And with some patients, it's about girth and not about weight. But oddly enough, we found out when we were redoing the bariatric SOP that the that the bariatric stretchers aren't any more wide than our everyday stretchers. It's just the weight limits that we have to worry about. Again, you can see the issues. This is not going to be a quick move for either one of these patients. And again, I say this, I said it before, but I think that we have to, when assessing a bariatric patient, we have to be sensitive to both their physical and psychological needs. They know the issue, and they know the stigma that is associated with obesity, particularly morbid obesity. I mean, you watch the television, you look at magazines, newspaper, everything's about skinny, thin, clothing, how you look to somebody. And obviously these patients are the polar opposite of what society thinks people should be. I'm not sure how we got to that point, but we are. So I think psychological assessment and treatment is equally important. And reassuring them when we start to move, you have to please tell them what we're going to do and how we're going to do it and why we're going to do it. Because a lot of these patients haven't been out of bed. I mean, go back, these patients haven't been out of bed and walking around in quite some time. So they're going to be a little apprehensive when we start to move. So we have to give them some reassurance that we're going to be with them. We're not going to let anything happen to them when we make the move. So, assessment. Do your general assessment. When observing the general appearance of a morbidly obese patient, the provider will often observe the patient to be very edematous, particularly in the extremities, with weeping sores, ascites, skin breakdowns, with weeping, dermatitis, and maceration of the skin folds. A lot of infection in these skin folds, so please be careful. Universal precautions with these patients is a must due to the possibility of infections. And there's some studies that suggest that morbidly obese patients, and we'll look back at them, these two patients that have not been out of bed, particularly a lower patient has not been out of bed for a very long time. When we start to move patients, we can trigger the clot that could bust and move. So keeping the lower extremities as still and immobile as possible is very important when we move bariatric patients. Determine the patient's overall tolerance with activities, particularly ambulation. Ask them, do you get up out of bed every day? When's the last time you've been out of bed? How far are you able to walk? And do you need assistance with walking? If the patient is seated, in a normal resting position, this may be the most comfortable and practical for the patient. And again, you take this within context. If the bariatric patient that we have to transport is able to walk and walk with minimal assistance, that is often the easiest way to do it, not only for the patient's overall well-being, but for the provider's well-being as well. Because anytime we affect the move, particularly with bariatric patients, it's going to have consequences. And we want to minimize the negative consequences that any move happens to. Neck structures commonly hidden by subcutaneous fat. Are we likely to EJ these patients? No. It's almost impossible. Thoracic structures, pulmonary assessment is difficult due to increased fat. When you listen to lung sounds, heart sounds, they're often going to be diminished. Ascites, producing rails, is common in morbidly obese patients. Immobile obese patients are prone to pneumonia and hypoxia going to acute illness. So we often find a lot of these patients are hypoxic. Palpitation of ankle, knee, shoulder, hip, and back structures can prove difficult. And oftentimes, are you in pain? They'll say yes. But the musculoskeletal pain in obese patients is common. And just like geriatric patients, you ask them, are you having any more increased pain in these areas than you normally would? And what they'll often say is no. Because they're immobile, most of the time, when we start to move, that's when they're going to see the increased pain, particularly in musculoskeletal areas. Shouldn't be too concerning because we should expect it. Now, we talked about You must have the appropriate size blood pressure cuff. Blood pressure readings can be falsely reassuring in obese patients, as the cuff often overestimates the blood pressure. Borderline blood pressure could present as a shock-like state in the obese adult, particularly if the patient looks unwell. I'll say that again. A borderline blood pressure could present as a shock state in obese adults, especially if the patient looks unwell. One of the things that we've talked about is when the bariatric units come, we don't have this yet. We're still discussing it. Is to have a box on each bariatric unit that has what I consider bariatric appropriate equipment. Blood pressure cuff is the most common, and we'll talk about IV cannulation in a few minutes. But will our IV catheters cannulate in morbidly obese patients? The answer is no. They're simply not long enough. And for those that have been around, remember when the 14 and 16 gauge needles used to be 2-inch or 2.25-inch catheters. I'm not sure we shouldn't be buying 18 and 20 gauge catheters with a 2 or 2.25-inch reach, because we're not going to be able to successfully cannulate morbidly obese patients because of the high body fat. You can't find the landmarks. Pulse oximetry may not be as reliable due to poor circulation and the thickness of the skin. Now back to blood pressure cuff. Even a large thigh cuff doesn't work on morbidly obese patients. So I did make the suggestion that we should get some. I mean, we're doing all this training. We're buying this state-of-the-art bariatric equipment. We need to have some pieces of equipment that are bariatric specific, just like we have infant neonatal cuffs. We should have morbidly obese blood pressure cuffs. So we're still looking at that as well. So hopefully that will be able to come to fruition. EKG alterations. I hope you can see that. It looks a little bright there. Low voltage due to the size of their chest wall. Obese patients tend to have longer QT intervals, and they often have signs of left ventricular hypertrophy. And again, I hope you can see that well. If you look at the amplitude of the QRS complexes, very low voltages because of the thickness of the chest wall. What are the vital signs? Fever, tachycardia can be early signs of leak after a surgery. What are the physical findings? Where is the pain or the complaint? Post-surgical complications, obviously in bariatric patients, will be the abdomen. If unstable vital signs when the patient is deteriorating, again, ABCs, O2, IV, monitor, and fluid bolus. But I think our protocols this year: 250 cc bolus and reassess. I think this is paramount, just like it is in congestive heart failure patients, particularly paramount in morbidly obese patients because of all their underlying comorbidities. We don't want to fluid overload these patients, but I agree with Dr. Barinholtz. Obviously, if they're decompensating and they need fluid, then we're going to give them fluid. Just be very cautious and have your eye on their vital signs, particularly lung assessment. Can we complicate their issues when we lay them flat to transport them out of their environment? Sometimes, yes. But I think when we get to the bariatric stretcher or outside to our stretcher, at a minimum of 30-degree elevation is appropriate, unless it gives them discomfort in their abdominal area where the complaint may be. Again, where's the complaint? Is it in the respiratory system? You have to assess their airway. Consider difficult airway needs early. And we'll see some slides as to why this is important. I hope Dr. Barinholtz will chime in here. Digestive system, is it in the digestive system? Is it in the cardiovascular system? Trouble breathing, chest pain is often a common complaint in obese patients. I've cardioverted some morbidly obese patients. I've given morbidly obese patients Adenocard. That's the easy part. The hard part is finding vascular access, particularly vascular access in the right area if we're going to be giving cardiovascular medications. So, in general, how are we going to manage these patients? We have to perform an assessment of the patient and the scene. You take a look at the patient on the left. You take a look at the house they're in. Are we going to come out the front door? No. Are we going to come down the handicap ramp Absolutely not. So alternative methods of extrication are particularly important. And this is where the truck officers, the squad officers, can be very, very helpful. If we have an acute bariatric patient where we have a long extrication time, do we have to remove the door? I mean, I remember years ago on Kavanaugh Road, I had to take the door out and brace the wall. And unfortunately, that was a rental property that the patient was in, and the landlord kept getting upset. You know, so those are all considerations, but the end goal is appropriate patient care. So these are long moves. If we have an unstable patient and we need medical direction, our medical directors are always available. I know EMS 5. We're so fortunate that four of our medical directors are in my area, so I see them a lot, and they can provide valuable insight to the management of these patients. I know Dr. Pollack would come out to Kavanaugh Road, and Dr. Nager, if those of you remember Dr. Nager, it was sometimes easier to treat this patient where he was than to be able to move him because the moves aren't practical. And at the end of the day, a private ambulance company has to transport these patients back in, often with our help. So careful scene assessment, plan every move. I can't overemphasize that. Later on, when we roll this out, the new version of the 600-26, the bariatric SOP, you'll be able to stop the program at your leisure, just like any other LMS program. You'll be able to click on the link at the top, and the new bariatric SOP will be there. I didn't put it up yet because it hasn't come out, so I don't want to put that out now. What are our considerations? Obviously, overall size of the patient. Is the patient ambulatory? Does the patient's physical condition or immediate medical condition prevent ambulation? And what is the clinical condition of the patient, including the patient priority? And this is where conversations between the provider and the truck officer or the squad officer is paramount, just like PI rescues. Is there an intervention that we have to do now? Can we get in and do it? How are we going to plan this extrication? Because remember, every reaction, there's a reaction, and it could be critical for the bariatric patient. How quickly do we have to get them out? What's the location of the patient and means to egress? I had a 600-pound patient that was on the second floor of a split floor of a house where the stairs, you could see through the stairs. They were sort of circa 1970s, and the stairs made a 90-degree turn. I had to call the ATR team because they had to brace the stairs from the basement up before we could get the patient out. What's the structural stability of the location? I've been on the second floor of very small homes where the patient's in the room, and there's also 12 people in the room. What kind of stress are we putting on the floor? And it was a very critical event one night where we couldn't put the amount of providers we needed on the second floor because we could see the floor sag the more people we had on locations. We had to do a Stokes basket evolution out the window, which means we had to remove the window and remove some of the structural supports in the house. And think, what resources do you need? What resources do you have on hand? So get resources there as quickly as possible. Your truck company officers, your squad officers are excellent resources for this. They know how to do the things. ATR team is definitely a consideration. If you feel you need them, call them early. They have the expertise and the equipment to help us facilitate these moves. What do we need? ALS unit is a must. EMS district officer, engine company, and we're going to request a bariatric unit if needed. I'm going to defer discussion about the bariatric units now because we're going to have very soon, I believe, we're going to have more to come with the utilization of the bariatric units. I know the Fire Academy, or actually, no, I'm sorry. I want to give Station 1 credit for this. They put together some slides that I was shown the other night on the new equipment. So that will be rolled out. I hope we will incorporate it here at the end of our presentation with the new bariatric units, because I think having a discussion about the needs of the bariatric patient would be remiss if we don't show the new bariatric units, because they are just a little bit different than what we have now. What do we need? I give Pikesville credit here. Do we need a tower? Do we need a crane? Those are all resources that we should consider early on. Airway. Airway can be very, very difficult in morbidly obese patients. Obese patients can desaturate more easily, and this is why I say if we can prevent them from laying supine as we move them, we should. Bag valve mask ventilation is obviously way more difficult in the bariatric patient. This is really a two-person procedure, like we were taught. Intubation is difficult due to immobility of the neck and the neck structures. I saw a slide once where it was a video laryngoscopy of a morbidly obese patient, and when you tried to view the cords, there was so much fat around the cords you really couldn't make out the structure. So consideration of a king airway for intubation should be considered. So this is why I hope Dr. Barinholtz will come in and give us some pearls of wisdom. When you look at the plane that we always talk about, look how much padding the bariatric patient needs. If we look at the upper right-hand slide, are we likely going to intubate this patient? No. If we look at the bottom right slide, once we pad under the head and the shoulders, look where that gives us the plane. Would you agree with that, Dr. Barinholtz?
Yeah, it's exactly right. It's like a bump that goes under the shoulder blades, and the idea is to get the right behind the ear, the mastoid process, directly horizontal from the sternal notch.
Yeah, and I talked about earlier that a bag valve mask ventilation is difficult and should be a two-person maneuver. I forgot that this slide actually shows that. Let me go on here if I can. What's happened here? Oh, okay. Oh, there we are. Breathing. Work of breathing is increased in the bariatric patient, ideally, or rather, all the time. They always present with some mild shortness of breath. And again, one of the questions, are you having any more increased shortness of breath today than you normally do, and when did it begin? Bariatric patients that are able to ambulate with assistance, be careful with dyspnea on exertion. If they feel the need to stop and take a breather, let them do it, because we know that they desaturate more quickly and that their work and breathing is increased. And if we have them ambulate, which again is sometimes that's the best route to go, their work of breathing can be increased and they can become even more dyspneic. Try to avoid placing them supine. Ideal position is the reverse umbrella position. Where are we? Supplemental oxygen should always be provided. I talked about CPAP. Don't go out and do this tomorrow. More research to come. Again, I'm just throwing these things out there because there's a work in progress. Just when I teach geriatrics, I say, if we have to do a hip immobilization, and we don't have our scoop stretcher, what else can we use? And we talk about using the KED. A lot of people say, "Oh, that's a good idea. I never thought about the KED for hip immobilization." Well, this is the same thing. Academically, you would think it will provide the relief that they need if we have to lay them supine. And the respiratory drive has to be constantly monitored, because if we lay them supine and we don't provide them with supplemental oxygen, they won't have a respiratory drive because they can't breathe or the increased weight in their chest cavity. Circulation, ECG should be monitored. Have to use the obese cuff. We already talked about that. But even our large thigh cuffs don't work on the morbidly obese patient's arm or even their forearm, depending upon their weight. If we use a standard cuff, even on the forearm, we will artificially elevate the blood pressure. So hopefully we can find blood pressure cuffs that are suited for morbidly obese patients and have one available in all three of our bariatric units. So more to follow on that. Acute complaints, IV access with a large bore IV. Vascular access is difficult. And again, we already talked about this. Our normal size 1.5 inch catheters may not be long enough to cannulate a morbidly obese patient, even in the back of the hand. And I'll show you one spot that's often that you may be able to use if you're going to cannulate the morbidly obese patient. Please check the patency of the line, because sometimes we don't know if we're in, and you may not see that infiltration right away with all the large subcutaneous fat, depending upon how deep we are and whether or not we're actually in the vein. So please keep an eye on the patency of the line. An alternate IV site in morbidly obese patients is the axillary vein. And I'll show you a slide on that. If the patient is not ambulatory, limit the movement of the lower extremities, as obese patients are further at risk of pulmonary emboli. We already talked about that. But an alternate IV access site in the morbidly obese patient is the axillary vein. And you can see it here. Then the skin is often thinner in that area, and you should be able to access that vein. Stand by. You'll be able to access the axillary vein fairly easily, more easily in the bariatric patient than other veins, because the skin is often thinner here, but you may have to pull up and around to stretch the skin out in order to find the site. So please consider the axillary vein in a morbidly obese patient if IV access needed and you can't find it. Can you drill bariatric patients? Yes. The problem is finding your landmarks. It can often be very difficult, even for IO access in morbidly obese patients. Circulation, there's no need to adjust the dual setting for biphasic defibrillators. I don't think, well, I know we don't have any monophasic defibrillators left, but biphasic defibrillators, you do not have to adjust the dual setting to overcome the transthoracic resistance, because the biphasic monitors will do it for you. A standard dual setting in a bariatric patient is appropriate. And some of this is very old. I said if using monophasic defibrillator in a patient over 350 pounds, you have to go directly to 360 joules. This is no longer appropriate. But I say that for people that have been around a while that remember the monophasic defibrillators. You had to adjust the dual setting. Now we do not, because we have all biphasic defibrillators. Drug dosing. Drug pharmacokinetics is a problem in obese patients, and please, Dr. Barinholtz, feel free to chime in with any words of wisdom you have. And I talked about this before. There's limited data on resuscitative pharmacology use in morbidly obese patients. There was only one article that I was ever able to find was written by a doctor in Minnesota. He was the head of an emergency department there, and he wrote an article, I think it was 2003, 2004, on resuscitative pharmacology in the morbidly obese patient. And I was fortunate enough to be able to speak to him by phone. And I said, this is a clinical interest of mine. We're trying to develop some training for our people. Do you have any words of wisdom for me on resuscitative pharmacology and altering the dosage in these patients? And his answer was no. It is trial and error. I see his point. I, to some degree, don't accept that, because I think trial and error is difficult. And when you even talk to our emergency department physicians, when we bring in a morbidly obese cardiac arrest patient, it is trial and error. If this drug is given and it doesn't work, we'll give more. But again, only one article that I ever saw on resuscitative pharmacology in morbidly obese patients, and this is the doctor that referred me to the veterinary literature when drug dosing large animals. I said there wasn't a stigma before, but then I associate drug dosing to veterinary pharmacology. But, the science is what it is. Some animals that have the human structure do have a very high fat, have high fat content. So the veterinarians have figured this out. We have not figured this out yet in resuscitative pharmacology in morbidly obese patients. Any words on that, Dr. Barinholtz?
No, I think you covered it exactly. You give the standard dose, or if it doesn't work, you give more.
I do have some. The lipophilic and the hydrophilic properties of the drugs should be known when dosing our pharmacology in morbidly obese patients. Lipophilic refers to the affinity. Lipophilic refers to the affinity for fatty tissue. Hydrophilic means it likes water. Lipophilicity, hydrophilicity refer to the solubility of something in lipids or water. Lipophilic substances tend to be nonpolar. Hydrophilic substances tend to be polar. So we really have to know the lipophilic property of the drug in order to know if standard dosing is appropriate, or do we have to alter the dosage. Now, if somebody laid a quiz out in front of me and with all the pharmacology that we carry and said, is this a lipophilic drug or a hydrophilic drug, I'd fail, and I'd be driving a day work medic unit somewhere as an EMT, because I don't know. And I'm trying to work with the Maryland School of Pharmacy to help me figure that out. Because again, there just isn't that much data because the incidence is low and the study population, that is the morbidly obese patients, again, they don't make good study subjects for drug companies. And particularly, when you look at resuscitative pharmacology, such a small portion of medications that the studies simply aren't there. Well, from my perspective, from our perspective, that's not good enough. I want to know so we can treat these patients effectively for the drugs that we give them. So hopefully more to follow on that very soon. If I can get somebody to help me with the lipophilicity or hydrophilicity of the drug, hopefully we can sort out if we need to alter the dose or is our standard dosing and our protocol is appropriate. I don't have the answer for that, not yet anyway, but I'm going to get it. Now, there are some drugs that we know, lipophilic drugs such as midazolam need to be dose based on total body weight. Therefore, the doses need to be much higher in the average adult. We don't do that because our protocols don't reflect that. Because again, this is a work in progress. I don't think we're there yet. Hopefully we will be shortly. Hydrophilic drugs such as ketamine are based on ideal body weight. They don't need to be altered. But there are some drugs that we carry that we have to alter the dosages yet. I don't think we're there to do that yet. I don't recommend it until we have the science and until we're sanctioned to do so. But again, I'm putting these things out there because it's information that we typically have not heard before and we've not been exposed to. But I think hackers are getting bigger. I think we see, and anecdotally, you all know this, we see more and more obese patients in our practice setting in the field, but our education is not caught up to it yet. 25 years ago, this is where we are with geriatric patients today is where we were with pediatric patients 25 or 30 years ago, and we've learned through education. The pediatric folks have done a great job in educating us about the needs of pediatric patients. I don't see anybody leading the charge for education in bariatric patients. That's why I kind of took up the charge, just like I did with elderly, because I think we do see these patients on a regular basis, and we should know as much as we need to know, but the science just isn't there. So more to follow on drug dosing, but it's just, I want to throw it out there so you have something to think about. Trauma in morbidly obese patients. Studies suggest that obese patients have poor outcomes in blunt trauma. They're 8 times more likely to die. They're less likely to wear seatbelts because they don't fit in them. And it's primarily related to pulmonary failure and sepsis. I had a 1050 PI rescue one day with a morbidly obese patient. And oddly enough, he was in a Mini Cooper. I don't even know how he got in there. He wrapped it around a pole, and we actually had to have the medical director come out to give us some assistance because we had to unwrap this car around this morbidly obese patient, and it was a very difficult extrication. And ultimately, he did not do well. So again, when you look at blunt trauma in older patients, they're 8 times more likely to die. Anecdotally, patients that are morbidly obese that get stabbed in the gut, does a small knife reach the organs as they would in a skinnier patient? The answer is no. But blunt trauma patients are 8 times more likely to die. Cervical immobilization is much more difficult due to the short, thick neck. A conventional power may not be effective. Rolled towels on either side of the head is an alternative. Anecdotally, we call those bull necks, and we've all seen patients where you're just not going to get a collar on them no matter what. Padding, place the padding under the head if they're hyperextended, just like we saw in the slide for the intubation slide. We want their plane to be neutral. It's like bariatric patients that are kyphotic. We don't want their head hanging over the backboard because we can damage the neck structures. Trendelenburg is preferred for morbidly obese patients. I think I'm the only one that has ever called for a bariatric unit at a 1050 PI rescue. Dispatch questioned me, you want a what? Because we knew this patient was not going to fit on a stretcher. He was not going to fit on a backboard. We could not get a collar on this individual, and he was not going to fit on the regular stretcher. So we had to call the bariatric stretcher. So think try to think outside the box. And I think we all do a great job. I'm on my 35th year this year. And no, I'm not going to retire for those of you that are high on the lieutenant's list. I always say I'm on the tippy plan. I know you're here. But over my 35 years, I've seen our providers on the suppression side, on the EMS side, we always do think outside the box. I think we don't give ourselves enough credit for doing it. But particularly with bariatric patients, we need to do that. We need to think outside the box. What do we have? Where do we need to go? How is the move going to be affected? And does the equipment that we have, is it going to work? What else do we need? What else do we need to call to the scene that we don't have? And I did use the bariatric stretcher on the 1050 PI rescue, and it worked fairly well. Now, this is the bariatric stretcher that we have. This is the bariatric unit. Some of these slides may change. 1,600 pounds in the lower position. The lower position is where we want to keep this stretcher when we move patients. We don't want to raise it until we absolutely have to. And I think everybody that's used the bariatric stretcher or transported the bariatric patient, the lower to the center of gravity that we can keep, the safer things are. I've seen one patient, obese patient, on a stretcher that tipped. It was not good. It was not good for the patient. It's not good for us. We feel bad when things like that happen, but more importantly, nothing that we do, nothing that we ever do should ever injure a bariatric patient. I know of one case where we used a standard stretcher. The straps did not fit around the patient. The crew opted not to belt the patient, seatbelt the patient on the stretcher. The side rails didn't come up because they used a standard stretcher. And when they made a sharp turn, the patient rolled off the stretcher, wedged themselves in between the stretcher and the bench seat. The unit had to pull over, had to call truck company out, we had to extricate the patient off the floor between the stretcher and the bench. Two things happened. The worst, of course, is we injured the patient. And the second thing is we paid out. We were negligent, and we don't want to let that happen. So please think through every move. 9-foot straps. If the stretcher straps won't work, use our 9-foot straps. Will spider straps ever work on a bariatric patient? No. 9-foot straps, and I think this is something that we also need to consider in our new bariatric units, is about 4 to 6 9-foot straps, because sometimes our standard stretcher straps are not going to work on bariatric patients. But before we move them, we need to make sure that they are that they're properly secured, because we don't want to injure these patients. So these slides will definitely change. This is what we have now, the use of the ramps, the ramp system. This set of slides will be replaced as we look at the new bariatric units. I've seen the new slides, but this is what we have now, and they're going to be very similar. The crews the bariatric units are going to be housed at station 1, 9, and 56. So we want every battalion. The people who house the bariatric medic at their stations, they will be the best ones to set the equipment up. They will be, obviously, they're going to be receiving more training with it. They use it on a frequent basis. So they're the best ones to, when they bring it, they would prefer to set it up and get it ready for you while you take the time to focus on the care of the patient. But I know that the ramps will be similar. They have a winch system, which is carried in a box, similar to this. Our new units will have the same thing. But again, all these slides will be replaced. The hook, for those of you who may have not had the opportunity to be involved in bariatric transport, the stretcher is pulled into the medic unit by way of a winch and cable system. Does somebody have to be at the foot of the stretcher to guide it? Yes. Ideally, there should be 3 patients guiding this thing. 4 patients, the one controlling the winch, 2 on either side of the stretcher, and 1 at the foot to make sure that the wheels stay in the middle of the ramp. And the person sitting on the captain's chair is ultimately the one who will be guiding the move. Now you can even see this, the cable is going out center, but it's skewed off here. So 3 patients, 3 people, 3 providers, one on either side of the stretcher and 1 at the bottom to make sure that it goes up the ramp, because it will move. And if it starts to skid against the side of the ramps, it'll be difficult to move up. but both providers and the one at the foot can control if it's going to stay in the middle. This is the stretcher going halfway up. And again, the technology is going to be the same. I think the ramps look a little bit different. I got a chance to see. What don't we want to do? We don't want to look at the bottom right-hand corner. We don't want to do that because for lots of reasons. How difficult do you think this patient is having of breathing when they put them in this sling that they have? And the other thing that we don't want to do, this patient is sitting on a front end loader. Why do we do this? It's the right thing to do for patients. Several years ago, the city of New York, Chicago, and Philadelphia were successfully sued by morbidly obese patients under the ADA accommodations because things like what we see in this slide actually happened. They were not moved appropriately. The city of New York actually has an ordinance that there will be a minimum of 2 bariatric patients. I'm sorry, there will be a minimum of 2 bariatric units in every borough of New York City to be available for the handling of bariatric patients. I think that's not the reason we do it. We do it because it's the right thing to do. I think we're leaps and bounds ahead of what other people do. You know, when I go around the country, I teach GEMS. I kind of get into these conversations about, you know, what do you do for morbidly obese patients? Nobody has an answer. We do the best we can. We take the stretcher out, we unlock the ram's horns, and we unlock the bolt, and we drag them up on a sheet, and we lay them on the floor. We have evolved leaps and bounds over doing that. And I remember when we used to do that. We've learned over the years that that's not the right thing to do. But I think what we do in our department, we're leaps and bounds of ahead of what other departments do in terms of the care of the bariatric patient. And generally, I don't think we give ourselves the credit that we deserve. I think we're more hard on ourselves than we need to be because we are doing some of these things. I don't think you would ever see us do anything that's like in either one of these slides because we're taking the time to get the training, to know how to assess, move bariatric patients, and we're buying the right equipment to be able to affect the move. So, in conclusion, we know obese patients can be challenging. You have to think about the assessment, the transport of these patients. How are we going to get them from where they are to where they need to be, which is definitive care, without causing any more harm to the patient or exacerbating their symptoms? Consider additional resources early. The earlier we can get the resources out, the better off we are, and we can have a coordinated discussion about what's the best way clinically and logistically. And this discussion has to be had with both the provider and the truck officer or the squad officer. We have to come to a joint decision because we have our perspective on what we think should be done. They have their perspective on, because we're calling them out to say, okay, we need to get this patient out. And they're going to do it because they're very good at what they do, but we have to consider the effects of every move that we make with bariatric patients. So this is a joint discussion that has to be had between the providers and the people that are actually going to be affecting the move. And again, professional and compassionate care to morbidly obese patients. I don't think we don't have a problem with that. I mean, I've been around a long time. I've been on a lot of bariatric calls. I think we do treat these patients very kindly and very humanely, as we should. But I think that we do a very good and compassionate job of moving these patients. Remember, they're aware of the stigma that society has on them. And now we're moving them out of their comfort zone, out into the environment, and into the hospital. I've even had the police, in one bariatric transport case, the whole neighborhood was gathering, and the patient was aware of that. And he said, I'm not coming out there because I don't want them to see me. So we got the police to move patients back. You could even use the tarps if you need to, off the engine or off the truck, because these people are very sensitive about themselves, and they're also aware of the stigma that society on them. So, questions? I appreciate you taking the time. I know, again, this is this whole bariatric treatment transport is a work in progress. There's some things that we know. Hopefully there's some things that you've learned that you can think about. There's more to come. I hope when we're ready to roll out the the training program on the LMS, we will have had the time to refine some things, and I hope to have some more answers for you for the questions that we've had asked. And, you know, hopefully if you guys do a bariatric transport and you make some good moves and you learn something, please feel free to email me. I'd like to know, Snyder@baltimorecounty.md.gov, or call me at EMS 5 on D shift. I'd love to know your best practices. I do look at best practices around the country. Some things I've learned, but again, I think we are delving into this more than anybody in any department that I've ever seen. But if you guys have some pearls of wisdom that you'd like to share, please feel free to reach out to me. That's all I have.
Lieutenant Snyder, what a great program. You can see the parallelism with the GEMS program. You really have done your homework. What a ton of great information.
Well, I hope it's something that we'll be learning more about. Bariatric sounds like geriatric, so I thought it was a good thing to get into. But, you know, sadly, don't see many bariatric geriatrics because sadly enough, those patients don't live that long.
Good point. So there are a couple of questions. When putting on 12-lead cables, is there an alternative way to overcome the excess skin?
No, standard 12-lead placement is appropriate for bariatric patients.
And then it says, and then in terms of the electrodes getting a better sync, there's no way to do it. I mean, the surface is what the surface is, right? You can't. Yeah, there's no way.
That's true. Yeah, that's true. I mean, our LifePak 15 monitors, you know, we look at, now I'm old school. I mean, we had to actually physically change the leads to do lead placement, but we don't have to do that anymore. Our LifePak 15 is looking at a variety of angles, but no, standard lead placement is appropriate. Moving the leads, it's not going to do anything. There's going to be low voltage no matter where we place the leads.
Agreed. Does dispatch usually know patients are bariatric?
No, that's one of the things we talked about. You know, when I spent my 7 months in ADO in 2015, I did have some discussion, and we found out that no. And if Captain Stewart is on this, he might be able to provide some more information. Lenny, if you want to chime in and you're here and you have the capability, I don't think that asking the patient's weight is a standard question that the dispatchers ask. Now, some morbidly obese patients themselves or their families will say, hey, this patient is over 300 pounds or they're very heavy. And if we get that in the call comments or dispatch may send an engine, but typically I don't think that they do.
A lot of great accolades coming across. Ashley sends out a message, don't forget to sign in, and sent out the link again. There's a question or comment: when thinking about patients remaining in their home and getting needed treatment, would consult with bariatric ER or available Baltimore County Fire Department medical director?
You know, that's a good question. We've been back and forth with that. We have outstanding medical directors. I want to say that in front of Dr. Barrett-Holt. You know, I travel around the country teaching GEMS, and I say, how often do you guys interact with your medical director? And overwhelmingly, they say, I don't even know who they are. And historically, you only saw your medical director if there were a bad circumstance. But we have a lot of knowledgeable medical directors, and I think that they are absolutely a good resource. Now, you know, some have different expertise, critical care, orthopedics, pediatrics. Is it feasible that we have a bariatric surgeon that we could call? And I know the answer to that. If you call a bariatric surgery hospital, you're going to get an ER doc who probably does not have the surgical expertise to answer some of the post-surgery bariatric complications or provide any advice on the logistics of moving patients. I think we're the subject matter experts in moving patients because we do it every day under adverse circumstances. And hopefully we've learned a little bit about what works and what doesn't work, or what can and can't work with bariatric patients. But I don't know. Is there a source we can go to for very complicated bariatric patients? I think the first source would be our medical directors, because oftentimes we have medical directors who are actively wide and are willing to come to the scene. I know Dr. Pollack did that many times for the patient in Dundalk. than the other 3 medical directors that we have routinely ride. So we have the district officers have their cell phones and we have contact for them. They're often an excellent source for information, but we've thought about that, and I'm still trying to work through if there's a dire need for that kind of medical expertise, how can we get it, where can we get it, how quickly can we get it? So that's more work in progress.
I also like the idea of eye care consults to help make sure that they're getting the social support that they need.
Absolutely. Like geriatric patients, bariatric patients often don't or won't reach out for any kind of support programs simply because of the stigma that's associated with obesity in this country. So kind of guiding them and letting them know that this is not an entitlement program or something that they shouldn't be remiss about reaching out to is good. I mean, it's all about the presentation, as we all know. Convincing. I get called a lot because the old person doesn't want to go to the hospital. So I'm the geriatric whisperer. I come out and I'm able to communicate with them and get them to do it. I don't think it's any different with bariatric patients. I think it's the approach and the willingness to get them to accept the in-home services that they need, because let's face it, they're not going to the outpatient clinic 2-3 times a week. So if there's in-home services that we can get for them, the better.
There are comments about the types of stretchers and using larger wheels on stretchers, for example. That kind of ties into a little bit of, will there be training or reinforcement about what standard stretchers can accommodate?
Yes.
Because certainly what a stretcher can on the ground versus, a power lift stretcher that's hanging out the side of a medic unit, those weights aren't the same, right?
No, and there will be, and we've had discussion about this. You take the 750-pound stretcher that we have, all of the power stretchers are rated to 750. Now that's 750 up or down. But my question to Stryker was, those little arms that raise and lower the stretcher, if you have a 750-pound patient that's straight out on that, are those arms strong enough to hold that weight? And I've actually seen arms that bent around and under. I don't know if that was a manufacturer's defect. We've had that question before. The minimum amount of time that stretcher is in that position, the better. Get them up, get them in, and get them secured. When we do the LMS roll-out presentation, at that one slide, I forgot which one it is, when you stop and you're asked to read the SOP, in the very beginning of the SOP, we talk a lot about the stretcher's capabilities that we have on the units, what their capability is, in terms of weight, in terms of girth, versus what the bariatric stretchers can do. I think a lot of, in the past, bariatric responses were requested when the stretcher that we have, the power lift stretchers, would have accommodated the patient anyway. Because remember, if you're in Halethorpe, it's going to take a little while for 56 to come down. If you're in a 44 box, it's going to take time for one to get there. So, yes, the earlier you call for a bariatric unit, the better. But take a look at the stretcher that we're currently using versus the weight of the patient. But in the revised SOP, there is, at the very beginning, a lengthy narrative on the current capabilities of the stretchers that we have versus the capabilities of the bariatric stretcher, so the provider can easily determine whether or not a bariatric stretcher is needed, or in the bariatric stretcher, the power lift stretchers accommodate the patient. Wheels, I've never seen a larger wheel. The wheels are not any larger on the bariatric stretcher than they are on the power lift stretcher.
Good. And then there was a comment that if a patient needs an x-ray, one district lieutenant got a unit from the aquarium.
What kind of unit?
I don't know.
Oh, well, yes. And I'll tell you, we used to routinely, years and years, and we're talking over 20, 25 years ago, we used to send a district officer down to the unit, and we used to borrow the proverbial whale sling. And that's how we moved bariatric patients. And I've worked with them before. I've actually donated some stretchers to them for use in their operating room to move dolphins around. But I don't know. I know that the zoo has a large open MRI for an X-ray equipment for their large animals. I know that some bariatric patients have transported there before for their X-rays. Getting portable X-ray company to come in, obviously, like the nursing homes, is the easier answer. That's another good question I'm going to look into, because I think it is a consideration. What they can get done at home is obviously better than if we have to affect the move. But that specific question, I can't answer.
Somebody else asked a great question. Can EMRC add a trauma line type consult with a specialist in bariatric medicine? Should that be considered by MIMS?
It's never been asked before. I don't think it's out of the question. You know, we have specialists available for everything, except this. You know, these kind of questions that we're asking about bariatric patients, we're asking about geriatric patients now. We simply don't have the answer. We talk about this like we talk about geriatric friendly emergency departments and a geriatric trauma center designation. That I don't have the answer to. That's an excellent question, but we have to get. I know there's a bariatric surgeon at University of Maryland. I can't think of his name. Kligman, you may know him. He was a trauma surgeon, and he moved he redirected his specialty surgery capabilities to bariatric surgery. But he was the medical director of a fire department. So this is a guy that obviously knows our perspective. Was an emergency room physician, was a medical director for a fire department, is now a bariatric surgeon. There's the ideal guy, but it's never been asked before. And I think if we ask EMRC, I think if somebody had a consult an hour after this presentation and they asked EMRC to bring it online, they probably fall off the chair because they don't know where to get it from. I don't think that there's the connection between where to get that type of expertise. Is it something we should look into? I absolutely think it is. We have trauma centers, we have pediatric centers, we have that expertise available. Should we have it available for this? Perhaps. But we have to work on the logistics of how to make the connection and connecting to the right person that will be able to give us the answer. I'm making notes on all of this because these are great questions. Moving forward, we need to look at.
I think that's all we have in the chat for right now.
If anybody has anything, questions, concerns, comments, best practices, something that you've done that worked well with a morbidly obese patient, EMS 5D, email me. I'd love to hear from you. Or if you just have questions about how do you think we should do this, if I'm working, please feel free to call me. I'm always available to provide what information I can.
Thank you so much. Thanks for all the time and sharing the expertise. What a fantastic program.
Well, thank you for allowing me to do it. And I thank all the people who participated, because to do so means you're interested in this patient population. And I think that's a good thing.